Good afternoon, everyone. So my paper is Incidence, Cumulative Mortality and Factors Affecting the Outcome of COVID-19 Associated Mucormycosis from Western India. Okay. So this is the table of contents. So coming to the research background, the COVID-19 pandemic has led to devastation across the world with multiple waves of infections. And in addition to the viral infection itself, there has been an increased number of opportunistic infections, including fungal infections. Ours is a tertiary care multi-speciality government hospital in Maharashtra. And our hospital had catered to more than 50,000 patients with moderate to severe COVID-19 infections. So we observed an outbreak of COVID-19 associated mucormycosis in March 2021, and we reported the underlying predispositions, morbidity, and mortality outcomes. So though some published studies reported outcomes, none of them used survival analysis to report mortality and morbidity. To the best of our knowledge, there were no studies addressing the cumulative mortality rates. So the outcomes from a single multidisciplinary center carry merit in terms of more thorough documentation. So coming to the methodology, this was a retrospective study at a tertiary care hospital. Informed consent was obtained. Case records of COVID-19 patients with a diagnosis of CAM were identified. Patients with minimum follow-up of 30 days were included. And the patients were classified into proven, probable, and possible CAM. Ophthalmic manifestations were recorded, and the basic demographics and complete diabetic profile was recorded. A potassium hydroxide mount was prepared. Saburod's dextrose agar was used to culture the fundus. A CT or MRI scan was ordered. Time interval between COVID-19 recovery and the onset of CAM was recorded. History of steroids was retrieved. History of requiring supplemental oxygen as well as non-invasive ventilation were all recorded. All the patients were advised endoscopic sinus debridement with lavage. The patients were administered IV amphotericin B when it was available in the wards. The time for adverse outcome was defined as the interval between the time of admission and either death or orbital exenteration. Orbital exenteration was planned for patients with advanced orbital disease characterized by the adverse ophthalmic manifestations. Outcome was recorded as death, exenteration, or recovery. The statistical analysis was done, and the survival analysis was performed using adverse outcomes in the censoring variable, and Kaplan-Meier curves were plotted. Then coming to observations, our hospital admitted 4,910 patients with moderate to severe COVID-19 and saw 67 patients with CAM. Of these, 28 were proven CAM, 5 were probable, and remaining 34 were possible CAM. The mean age was around 55 years. One patient had bilateral disease. Majority of them were diabetic. 9 patients were diagnosed with diabetes, and the CAM developed approximately 15 days after recovery of COVID-19. This was a comparison of the demographics and clinical characteristics. These were the factors associated with adverse outcome of either death or exenteration. These are some of the clinical pictures showing ptosis, then nasal eschar with facial palsy, palatal eschar, orbital eschar, ptosis with ophthalmoplegia with facial palsy. 84% patients had received steroids for COVID-19 management. Prolonged oxygen supplementation was needed by 52 patients. All patients had orbital involvement. 3 patients had an intracranial extension. Pansinusitis was the commonest involvement. Of the 67 patients, 26 experienced an adverse outcome, with 23 having died and 3 underwent orbital exenteration. Patients who had adverse outcomes were all diabetic. Patients with adverse outcome presented with much worse disease. A multivariable Cox proportional hazard analysis with the best fit model showed that history of receiving assisted ventilation led to nearly 7-fold increase. And in the same model, the patients who received amphotericin B had 67% reduced risk of outcome. Kaplan-Meier survival estimate was shown like this. Now, in this retrospective study involving 67 patients, we found that almost all patients had underlying predisposing factor, uncontrolled diabetes, and high rate of ketoacidosis. Prior use of systemic steroids and need for supplemental oxygen were the other strong predisposition factors. The onset of CAM was about 15 days after recovery from COVID-19 infections. Cumulative probability of mortality was 24% at day 8, and it was increased to 38% at day 20. We reported a relatively low incidence of orbital exenteration. And Sen et al. From the largest series reported 17% exenterations. The use of prolonged oxygen has been postulated to be a risk factor for CAM. However, 22% of these cases did not receive any supplemental oxygen. Similar results were reported by Sen et al. Drawbacks of a study are its retrospective nature and the lack of documentation of the duration of steroid use. The advantages of our study are relatively large number of cases of these very rare disease occurring in the form of an outbreak, allowing us to understand the disease behavior, mortality, and morbidity rates. To the best of our knowledge, this is the first study providing a survival analysis, cumulative mortality, and hazards ratios for factors predicting death or exentation in the CAM. The mortality indicators we found, that is the need of assisted ventilation in the past and the presence of severe orbital manifestations, can help physicians triage patients for emergency procedures and administrative systemic antifungals. So to conclude, we report the underlying risk factors, mortality and morbidity outcomes from an outbreak of CAM infections from a multi-speciality hospital in India. This is the first study reporting the cumulative survival rates. These are my references, and thank you very much.
Statistical data, so that in future, suppose if we are managing these cases, so we can limit the uses of steroid and that way.
Yes, we had documented that majority of our patients had received steroids in the form of IV methylprednisolone and followed by dexamethasone. So it was a major risk factor in our series.